Hi, my name is Jillian. I'm going to do this presentation on communication in palliative care. Lesson plan objectives. We are going to discuss the key communication barriers that exist in palliative care between patient to physician, patient to nurse, and physician to nurse. We're going to educate nurse and staff about the importance of communication in palliative care and end-of-life discussions. And we are going to learn some helpful skills and tips in communicating with these patients and families and how we can integrate these back into our practice. This is just a little information about the background on palliative care. In the late 1950s, Dr. Saunders advocated that only an interdisciplinary team could relieve the total pain of a dying person. This is still the core concept of palliative care today. In 1974, Dr. Mount coined the term palliative care to help avoid the negative connotations of the word hospice. In 1997, the Institute of Medicine released a report on approaching death, improving care at the end of life. The mid-1990s was a big movement for palliative care with the growing attention to quality of life at the end of life. This was also the same year that the Oregon Death with Dignity Act was passed, so there was a lot of public awareness on media on death and dying. In 2000, PBS launched On Our Own Terms by Bill Myers. I do recommend watching this if you haven't seen it already. In 2006, the American Board of Medical Specialties recognizes hospice and palliative care medicine as a specialty. And finally, in 2011, the Joint Commission began crediting inpatient palliative care programs across the U.S. Now I'm going to discuss some key communication barriers in palliative care. Lack of personal experience with death and dying can increase reluctance to discuss topics. Many do not know how or where to initiate services for our patients in the inpatient setting or outpatient setting. Fear of one's own mortality. From both patient and healthcare providers' perspective, resulting in the avoidance of the topic altogether. Fear of not knowing an answer to questions and whether or not to be honest answering. I believe this is one of our most common barriers to communication we face as healthcare providers. Language barriers can lead to disagreements between patients, families, care providers, and healthcare professionals and should be discussed open and honestly. A patient can recognize a healthcare provider's insensitivity by interrupting communication, patronizing, and not allowing a patient or family member to express their views. Often, humans avoid expressing emotions such as tears by avoiding difficult topics, something I think we've all done. This is something I often find myself guilty of, wanting to support a perception of hope for my patients and their families. We obviously want to see all of our patients get better and make it to their daughter's wedding or see their grandsons graduate high school. But we all know this isn't the case for every one of our patients. The way the palliative care program has helped me be a better communicator with my patients is not to make promises to my patients, to understand that it's okay not to know if you're going to make it to your daughter's wedding or if you're going to make it to your grandson's graduation, but to let them know that we're going to do everything we can to get them there. Communicating with patients and families. Building rapport with patients and families can help facilitate trust and understanding. Be honest and truthful. Elicit and request their values and goals and help them as much as possible to achieve these. Keep patients and families informed about the patient's condition and updates. Work with the entire team and see that they understand the care plan and that they communicate the goals to one another. Listen actively to validate concerns and needs to both patient and family. Provide a safe place for conversations about death and dying. Recognize the individual. Listen how the patient describes themselves. Find their uniqueness. Ask questions such as, how would you describe your illness and how it has shaped your life? These questions will also help determine what and who is most important in the patient's life, and discuss how the diagnosis is affecting them and what services we may have available to help to ease their troubles. Understand that each patient and family has life outside their cancer diagnosis. Encourage the patient to reflect on the past and share feelings about their life. Ask how much your patient, family, or caregiver wants to know. Has someone already spoken with them and answered all their questions? Do they look overwhelmed or overloaded with information? Illness can strengthen a family's relationship or cause relationships to surface in unexpected ways. Families with uncaring relationships, such as violence or abuse, often have a harder time coping with negative feelings, anger, and guilt. The caregivers carry an enormous burden. It is important to involve the caregiver when necessary, but remember to ask how it is affecting them as well. It could be interfering with their work or their own health. Remember to communicate with children, paying attention to their developmental age. Also, as we continue to see more patients in the pediatric population, keep in mind that children with cancer are often developmentally delayed emotionally and physically. Communication techniques in palliative care. Provide a warning shot before opening up with bad news. Rather than saying, "You are dying," say, "I regret I have some difficult news to share with you." Acknowledge the emotions that they are expressing to you. Offering a box of tissues can go a long way. Legitimizing normalcy of reactions by saying, "Anyone receiving this news would be upset," or "This can be overwhelming. What can I get for you right now?" Finding out what is under the emotions is important because they will still be there once the emotions are removed. Asking questions such as, "What worries you most?" can help facilitate these discussions. Showing empathy is something that most of us in our profession often do, but knowing the right time and place to do it is key. After a patient or family member has received bad news, be prepared for silence. It is generally uncomfortable to sit through this silence, but it allows time for them to process what has just been heard. If you are the one who just gave the bad news and you know the patient and family are going to another part of the facility, give the office or unit a heads up so they are aware of what just took place and can be better prepared. Make sure what you said was heard and understood by asking, "What have we not talked about today that is important to you?" Make sure you efficiently and fittingly use the word dying only if it's appropriate. To provide the lessened conflict, remember to actively listen, express, or explain your view. Refrain your statements and agree to brainstorm with your patient, family, and team. Summarizing helps to retain what has been discussed. You can say something such as, "Let me double check that I understand what you said." Always provide support, saying, "I am here to work with you and help you through this." 80% of communication is nonverbal. This includes body language, eye contact, gestures, and tone. Ensuring you always sit at eye level with the patient and family and that you are leaning forward towards them. These are some guidelines for encouraging conversations. Make sure everyone is comfortable and in a private space that they can speak openly. Make sure pagers and phones are off. Is your patient ready and willing to talk? Does the patient look in pain or uncomfortable? Are their eyes glossed over like they have been sitting in meetings in offices all day? Make sure you sit and listen what they have to say. Encourage them to talk. Use open-ended questions when needed. How are things going for you here? What has been helpful? Use comments like, "Tell me more." Be silent. Don't interrupt. When patients hear "I'm sorry," they often misinterpret a meaningless conversation, being aloof, showing pity, or that you're taking responsibility for any negative outcomes. Rather say, "I wish I had better treatments for your disease." Don't change the subject. This can often be a natural response when we want to avoid a difficult conversation. Take your time in giving advice and try not to give advice unless asked. If you are asking, doing assumingly. "Have you ever thought about," or "My friend tried"? Encourage reminiscing. Let them tell their story. This is a powerful reassurance that their lives have meaning. How can palliative care help your patients and families? Improved clinical care can help to assess and manage symptoms, help establish goals in care, and provide assistance to caregivers. More efficient use of resources available to patients and care providers. better care coordination to reducing hospital admissions and bringing the care back to the home and outpatient facilities. Can also assist in enrolling patients in hospice when needed. Cost avoidance. Multiple studies have shown that palliative care can save money not only for healthcare facilities, but patients and families as well. In conclusion, communication is a complex process in all circumstances, but becomes truly challenging in chronic and terminal illnesses. Remember that each team's main object should be to advocate for what he or she believes that is in the patient's best interest. True advocacy is best achieved when the patient and family have a primary role in their plan of care. The nurse's role is to promote clear, open communication among team members and the patient and family. An ongoing assessment of communication is vital and plays an important role in achieving total care. Thank you for listening.